Welcome to Be Time, everybody. I'm Beth Bierbauer, healthcare executive, author, and host of this podcast. Be Time is the podcast for individuals who want to invest in themselves and their careers through continuous learning. And each week on Be Time, I have the privilege of interviewing a seasoned executive, a company founder, or other business expert, and we talk about a variety of topics. So whether you're with a large company or small, inside the healthcare industry or out, Be Time has something for you to help you stay on top of your game. So let's get started. If you work for a Medicare Advantage or a Medicaid health plan, then you understand how important it is to close gaps in care. Gaps in care exist when the member has not received certain diagnostics or screenings according to federal guidelines. The most recognizable gaps in care are things like eye examinations, mammograms, and more. Health plans need to close gaps in care to stay in compliance with regulations, but also to improve their STARS ratings. In addition to messaging members, health plans rely on providers to close gaps in care. For example, a health plan may notify a provider of gaps in care that exist for a specific patient. The primary care physician then is expected to close that gap in care by either performing directly or scheduling a service. Now, the challenge with gaps in care is that providers are bombarded by the variety of health plans that they participate in, and they even get gaps in care messages from their own EMRs. So it's often difficult to sort through the noise and to take the appropriate time needed to follow through to ensure your patients have all the preventive screenings that they need. Our guest today is going to explain how his company, Stellar Health, incentivizes providers to close gaps in care. Michael Meng is the CEO of Stellar Health, which helps practicing physicians improve their quality and their financial performances by prompting providers and care staff to close gaps in care. They recommend value-based actions, and they offer real-time payments at the point of care. Anytime I hear the term real-time, I am intrigued. So I look forward to learning more from CEO Michael Meng about Stellar Health and what they are doing to close gaps in care. Michael, welcome to Be Time.
Thank you for having me, Beth.
We are very glad to have you here. Michael, why don't we start by setting a little bit of context? Would you help our audience understand, what's so important about closing gaps in care? And why is it important to the member? Why is it important to the provider? And why is it important to the health plan?
Yeah, I think so. The great news is there's a lot of academic literature, right, around these quality actions and gaps in care. So things like getting a colorectal cancer screening, especially if you have a history of it in your families, to prevent and catch colorectal cancer early. Or more commonly, I always tell people, most of us have been on a breast cancer awareness walk, right? Or raised money for that. Yet, in our country, this is crazy, 35% of the women who meet the age requirement of over 50 should be getting a mammogram every other year don't get one. So 1 in 3 women who meet the qualifying academic literature criteria are not getting one done. These mammograms are $100, $150, so they're not expensive. And it's an awareness question to get something like that done. And you either catch it early and have it, surgically removed, which is, while still invasive, non-terminal, or it becomes stage 4 metastasized breast cancer, right? And one is clearly a better way to treat it than the other. And I think that's what all the quality actions are for. It's things like that are really good for the patient. They're good for the system from a cost standpoint, and they really are better care ultimately. There's a lot of those types of things out there that we probably as an entire healthcare system should do better.
Got it. That's really, really helpful. Now, I've talked to many people that really deeply understand the STARS and the HEDIS, they're experts in that area. And they have shared that sometimes it's like finding a needle in a haystack in determining where you really need to drive your efforts to closing those gaps in care. And it has to do with the way STARS operates, right? It isn't just set bar. The bar changes based upon how well your competition does. Can you explain that a little bit? What is that, and is that the best way to approach it?
Yeah, it's a great question, Beth. it's a very interesting one in that it's very intelligent. Have to give you have to give the CMS and NCQA and the HEDIS folks credit. It's very intelligent, and the idea is more like I can't measure you on saying you're going to get all 1,000 of your patients to do this. But what I can say is I want 93% of them that meet the qualification to go get it done, right? And that's how I'm going to measure and standardize you as a larger provider group, maybe against a smaller provider group. And so there's these thresholds, and you're right, they move around from year to year, which is really frustrating for providers. I'd say a lot of times our providers, we give these presentations in physician dinners, and they'll say, yeah, the targets are always moving on us. So who likes to try and hit a moving target? And it's really frustrating. And in fact, I think a lot of the people who get good at this stuff, a lot of what they're doing is actually just strategizing and gaming the system. No different than how you might strategize in like Connect Four or chess. Like literally, you think about, okay, I have to get to 930 out of my 1,000 patients who meet this criteria. I got to get to that number. How am I going to go get to that? And that's why there's a huge emphasis, I think, on analytics being the important thing. But I think the big piece that analytics misses is, and for a doctor, you probably feel then like you're gaming the whole thing. You're not actually just bringing better care to your patients. You're actually trying to hit some specific game metric, which is, I think, what frustrates a lot of doctors out there. And again, probably intellectually the right thing, but it's very complicated. It's not easy to do. And I think we want to find simpler ways to still measure what great quality means.
Got it. And what are the implications to the health plan if they don't close an adequate amount of gaps in care? What does that mean to them?
Yeah, it's a direct financial and economic, right? And so when you clear 4 stars as a plan, all of a sudden that's a 5% difference in premiums, right? And when your entire insurance model is such where you have 5 to 10% net margin, which is what you collect or take home after paying out loss ratio or medical loss ratio in this case, 5% more can double that, right? Or triple that. So it's a very significant amount of money to go get to that 4-star level. When you get more advanced, there's things where at certain 5-star levels, you can actually do year-round enrollment, other advantages here and there. And I think that's why quality is so important. What I don't like about it, I will say just straight up though, is also that it's in itself a little bit of a stair step construct, right? So if you hit it, you're good, you're done. Versus if you don't clear the 4-star bar, you're kind of well behind the 8 ball, so to speak. And I think one big thing, we just put out a white paper study on this, that once you get to 4 stars though, you have to remain vigilant. You can't just, pretend that, just because you're there doesn't mean you're there the next year. And we call it falling from grace. So there's a lot of 4-star plans, we looked at it, who held it for even 5-7 years and then fell from 4 stars, fell from grace back down. And so you have to stay on top of this type of stuff. You can't just kind of say, I've achieved it, I'm done.
Yeah, well, I know it's a big focus, particularly of Medicare Advantage plans. Would you describe for our audience the traditional approach the health plans take to closing gaps in care? And then we'll get into what your organization does.
Yeah, this is one of my favorite questions because it gets at, I think, the root of the problem from my perspective, or what I think it is, which is you have to remember that insurance companies were built by actuaries, right? So they look at lots of numbers and historical record of it, which is what actuarial science is. The problem with that is then everything starts looking like a number to you, right? Like it's a stat. And there's nothing wrong with stats. I love my numbers myself. But I think what happens is because of that, most insurance companies then design their programs around quality to be exactly that. If you get to this level, I will then pay you this reward, right? And the problem with that is it ends up being a couple problems with it. One, it becomes retrospective in nature, meaning it's always looking backwards instead of looking forward at what you might do next, right? And that in itself there's a lag. The second problem is the rewards come after the year is fully over. So if you got some quality actions done in February, it may not matter to you financially until the following year, March. And that in itself is a huge problem, right? Imagine if I told you wouldn't get your paycheck for another year. And then on top of all of that, it ends up feeling, I think, to most providers like a report card. You're either a good doctor or a bad doctor. And I think the reality is neither are true. There's things you do that are good quality and you should do more of those. And there's things that if you don't do it aren't so great quality. And you should think about it more from that perspective. rather than it feeling like you're grading the doctor, so to speak. I think one of my favorite nuances also is that you may be 4 star, 5 stars in one health plan as a provider, and then 2 stars in another. So what star are you then as a doctor, right? Like in the end, they're just grades almost on it, and so that it doesn't really say that much. It says in this book of business, you achieved 4 stars is probably the right way to put it. So I think the problem is that they're always looking backwards at that calculation and that measurement rather than what can that doctor do next that is of great quality.
That's really interesting. Why might it be that a doctor would be 4 stars in one plan and 2 stars in another? What might cause that?
They may have paid a lot of attention to one health plan and the maybe sizable 1,000 patients they have there, but the one that they have only 100 patients, again, still important, right? Every patient's still important, but they may not have thought about that one enough. A lot of times it comes down to workflows, right? So it's easy to make a workflow for the 1,000 patients that you may have. And then when you have to make an exception process for the 100, that's a smaller minority of your book, that's when it gets kind of tricky. And a lot of times you don't even know. That's part of the problem too, is, the way that a lot of health plans approach this, by the time they actually give you the report card. So for example, we just finished the second quarter. I think the health plans are just coming around with, here's how you're doing through the second quarter. It's now August, right? So you already lost a month. And that data is probably 2-3 months old as well. So you're looking at April data in August and September to try and drive performance. That's not so great, I think, from a provider perspective either.
You make a really good point in that processes vary from plan to plan. So if you have 1,000 patients over here versus 100 patients over here, well, you're going to put your efforts towards the 1,000 patients because that's repeatable, repeatable, repeatable. As opposed to the 100 patients, those feel more like an exception. So it's not that you're not trying to pay attention to them, but it's habits are made by repeating things over and over. So the more volume you have with a particular plan, that makes absolute sense to me that the more attention you would give to those types of processes.
Well, and it doesn't have to be that way though. So if you think about a car manufacturing plant assembly line, a lot of times they have the chassis come out, and that chassis can be used for different models and makes, right? So I think we would say the same thing is true here. If you actually have a really solid workflow that could switch between the different health plans and lines of businesses, then you do the same workflow, but the things that you actually do at the finishings at the end may be a little different. You can design a workflow for that as well. Unfortunately, our healthcare system and most providers have not done so yet, but you can actually unify that. And that is something certainly Stellar aims to do.
Well, I would agree with you. And most providers are not skilled, nor do they have the investment dollars to invest, at least from their perspective or their mind, in technology to really help them do this. So that leads right into Stellar Health. So why don't you talk a little bit about what it is that Stellar Health does to address this issue?
Yeah, I think a lot of the themes we already touched upon, but when we look at value-based care and closing these gaps or doing this type of work, I think the biggest problems is if you actually put yourself in that provider's shoes, from their perspective, it's like, well, let me get this straight. You want me to do all these extra VBC chores, right? In many ways, I'm already busy. I'm seeing patients. It's adding on top of it. And they don't mean chores because they don't want to do it. Just it's additional work and layer of work. And then you also have to hope that me as a doctor, that all the other doctors in my group also do all these chores, which they may or may not do because you measure things at a population level. Now I'm not individually accountable. My whole group has to do these things to achieve, right? And then on top of that, I have to hope that in 18 months from now, when we reconcile it all, we did hit all the 4-star metrics and we get a big payment, which doesn't always happen. In fact, 85% of doctors out there have never seen a big shared savings or surplus check, right? So it's a little bit mythical at this point. What Stellar does is flips it all on its head. So first we take a bunch of data from the payer side to really know what needs to be done and closed, right? That the first thing that's important is don't do stuff you don't need to do and do only the things you should do, right? That's important. But that's not enough. Serving that up alone is table stakes in our opinion. What we also do is we actually pair every single action that we ask a doctor or their staff to do with a granular incentive payment we call a Stellar value unit. And if you know how doctors are paid today, they're paid on something called RVUs, relative value units. And I will contend I've never met a doctor who didn't understand their RVUs, right, or how to maximize their RVUs. So we said, why change that on them? Why not just use that existing construct? But instead, I'm going to serve up things like getting that mammogram done for that 50-year-old woman who has two children, right? We're going to serve those types of things up and pay you when you take the time to bother to do those things. And by flipping it on its head, it's now prospective in nature, right? Meaning you're choosing to do that next mammogram rather than not doing it. And you're actually rewarding for their unit of time. You're saying, if I'm going to ask you to take an extra 5-10 minutes to do this instead of seeing another patient in fee for service, I need to reward you for that. And so by flipping it on its head, we've seen tremendous results at getting a lot of this activity done in a way that I think providers really understand easily and are really happy with.
Now, are you seeing that, and I'm assuming you are, that providers are willing to take that extra step or to follow your process for a couple $100 more a month?
So a little bit more than that. Our average provider probably takes home closer to $1,000 to $4,000 a month. So it's a little larger than that.
Wow.
By the way, that's a commentary on how valuable these things are. Like truly, the payers who fund us recognize how valuable they are, and they want to share something. Our job, in fact, as Stellar, in some ways, is to take that money and share that, right, with the people who did the work. And then also our staff also sharing it as well. They take home an extra about $300 to $500 a month. But yeah, they are willing to do it. And there's two factors that go into this. We think a lot about. Number one, again, you have to make sure that the opportunity cost of their time was worthwhile, right? So a doctor can literally go see another 15-minute visit and instead worth about $100, right, for their normal fee for service. Or if I ask you to spend 5 minutes extra on something, it's kind of worth about a third of that time. So you have to price to literally how they make that indifference decision. And then the second big thing is that you really want to focus on that their take-home pay is enough. Sometimes I say this, is at the end of the day, we're all human. You just care about paying for your mortgage, kids' bills, groceries. We're all the same in that way. And that's what it's all about, is that take-home pay. And so the way we even thought about it was we want an average primary care physician to take home an extra 25% pay this way, and they will be really successful. And that's actually how we think about how to reward for this.
Well, that certainly would catch their attention, number one. And number two, it benefits the member or the patient because they're actually getting the services that they need. Now, you mentioned something I would just want to drill down on a little bit. You talked about the care staff. So the staff within the provider's office, they have the opportunity to, I think I heard you say, the opportunity to earn some incentives as well. Is that right? And what's the thought process there?
Yeah, that's right. And I think if you really get into the workflows, and a lot of our team members have actually served as medical kind of care coordinators before, you find that 80-90% of the legwork is actually done by staff, medical assistants, nurses, front desk staff. They're actually huge heroes in all this. And without them making some of this stuff happen in the first place, none of it happens, right? And I think any doctor who actually does really well at this will recognize that a lot of it is they set up, actually not that different than how maybe you may use an executive assistant or administrative assistant. They actually give you a lot of leverage if they set things up correctly. So, and what we're doing is we're not asking them to do the diagnosis, right? That's not even legal or compliant. That's not the point. The point is the doctor doesn't want to be sitting there clicking around trying to find where it is in that EMR. Can the medical system actually queue up the right information for that doctor? Then the doctor's only spending the most valuable 5 minutes with the patient. And by the way, they're not sitting there on their computer the whole time with the patient. They're actually interacting with the patient, right? These are all the things that we want to happen. And so for teeing all that up, we reward the staff member about on average 20% of the total dollars earned. So it's still very meaningful for them that they're actually really contributing and they're getting rewarded for that contribution in the same way. And again, it's not so much money that this takes the place of their normal job, but it's enough where it's worth them spending the extra 10-20 minutes a day to make sure this stuff is happening.
Well, that makes sense. And in this field, you don't see incentive programs typically in a provider's office. So having that opportunity based upon payment rates, depending on what some of these roles are, that's really meaningful to an individual.
Yeah, and I think a lot of people really want to take pride in their work, right? And it's hard to take pride in it when you maybe helped a bunch of these quality measures, and at the end of the year, you just missed the cutoff by 2%. And so you're not 4 stars. and all of a sudden it feels like the whole year was lost. Again, that's not the most positive message from a payer. The better message is every mammogram counts. The next one you get done is still worth something. And you, as the medical student, you help that, you get your share of that, and the doctor who did help that gets their share of that. That's how we make this really fair for everyone.
Great, great. Now, incentive programs in general will lose their appeal sometimes over a period of time. This sounds truly outstanding, but are you seeing that? Are you able to share any type of engagement stats?
Yeah, we get this question all the time, and a couple different stats. First, just to set the stage, we manage about 375,000 lives actively in the nation today. And when I say actively, I don't mean in a superfluous high level, we sort of manage, but we've never talked to them. No, we know exactly who that patient is. We have PHI on that patient. The doctor, we know who their doctor is, what they need to do for that patient, right? So it's very, when we say managed, it's very specific and hands-on. That breaks down to about 3,200 doctors nationally. So just who are on the platform today. What's kind of neat too is that they're actually logging in on average about 80% plus regular active engagement rate, which I think in the healthcare industry is extraordinarily high. And they're using us to prep. We call it in workflow. Are you in workflow with them? Now, every provider is a little different. So how you are in workflow may be a little bit different here and there, but that they are regularly logging and using it. What's really interesting too, to your point, is we were a little bit concerned, shiny new objects always catch people's attention. What happens in year 2 or 3? What we actually find is two things. One, we continue to drive engagement even higher. It can actually go from 80 to 85 to 93%. And then on top of that, what we're also doing is as you level up and do things, so getting a mammogram done, not the hardest thing in the world. You start adding harder actions to it, like a transition of care visit. Patient gets discharged from a hospital. You want them to do a transition of care visit and a med rec. That's a little harder to ask a provider to do. That's the level up, right? So first year, you might have focused all on these HEDIS measures. Second year, you're actually working on this next level of stuff. So there's always more to be getting better at in value-based care. And I think that's what keeps a lot of the interest. And, my favorite quote is my CTO once said, a lot of people, they come to Stellar for the SVUs, but they stay for the results and the performance. At the end of the day, actually, most doctors really want to achieve great care and results. That's really why they're there. The money is really helpful to balance out their time, but really they come for that initially, but they're really doing it because they are achieving great results. I just saw today, a lot of our providers who started in 2019 at about 2.5 stars in New York are all at 4.5 star plus, and they're maintaining that, and they're working on new things like transitions of care and harder things now.
But that's really terrific. And you're right. Most providers have decided to become a doctor because they really want to do the right thing. But to your point, they also have trade-offs they have to make in terms of how much time they can commit to certain activities. So I think this just really provides them the right incentive to continue to do the right thing and just make sure that they're making time for the right thing. Now, CMS obviously is the regulatory agency over all Medicare Advantage plans. Do you see anything coming down the pike, or have there been any changes recently that will either help your program in terms of closing gaps in care, or any concerns that you're seeing?
Nothing serious, except maybe the common rhetoric is all about DCEs, which we're actually very supportive of. I see it actually that as CMS's response to Medicare Advantage. They're saying, I want my ACO or original Medicare to kind of end up very similar to Medicare Advantage, and maybe, by the way, I can capture more of the margin if you choose to stay in original Medicare. And I think that's a positive tailwind. I don't think it's a game changer. I think it's just an evolution that will continue. And you'll see probably the two come into parity. I did a panel with the New York Healthcare Business Leaders Club a week or two ago, but we talked about this exact topic. So you will see that happen, but I don't see that as something that really makes it better for us. All it is a continued march and emphasis towards value-based care. So whether it's DCE or Medicare Advantage or even Medicaid, you're going to continue to see every single one of those move along. Because this stuff is just that important. I always tell people too, through the Obama administration, then Trump administration, now the Biden administration, believe it or not, the policy in this whole area has not changed. There's been some things taken a little bit further forward versus others, but this is actually one of the few things I think both sides of the aisle actually really agree on. And it's for the simple reason that it has to be sustainable. Healthcare in this country needs to be sustainable. We all agree on this. And this is the way forward. We still need people who are going to help execute and implement on the ground with real life doctors and patients, but the need for it is super clear, I think, to both sides.
What advice would you have for our listeners out there? Maybe they're part of a health plan that's really struggling to get provider engagement. What would you say to them?
I think the biggest thing is having extraordinary empathy for what their life and day to day is like. We really push this on our team that you have to really go walk a mile in their shoes for a second. And this is if you've ever been to a doctor's office lately, it's like they're running around, they're kind of sitting in the waiting room. They just so many patients, that they need to see and get to. Really put yourself in those shoes and what would make things easier for them. And the big thing I would tell the health plans is, take the first step on this. It's easy to always be like, well, how do I know? Will they do this and do this if I give them the money? I think there is money available in funding. And so take the first step, right? Take the first step because, there's always going to be a little bit of chicken and egg problem here. But if you can get them, if you go first, then they'll meet you on this. And then you'll build on this virtuous cycle. I find there's a lot of virtuous cycles and there's ones that are not so positive. So better to be on the positive side of that, and you can build towards it. Every one of our providers and payers are much happier for everything, that the fact that we've actually gotten both sides together on this.
I think that's really great advice. Providers oftentimes look at the health plans and say, wait a minute, I'm the quarterback for care. I'm expending all this effort, yet the margins are sitting over with you. And to the extent that you can say, wait a minute, we really do want to be a partner here with our providers, and you should share in that opportunity when you're doing the right thing, I think is really, really critical. And I think the other thing you mentioned earlier, Michael, which also is important, is that they don't want to feel like they're receiving a report card. What they're looking for is actionable information that can help them be a better doctor. So I think that's a really keen insight that you have that I just wanted to call out for our audience. So thank you for sharing that.
Thank you, Beth. Yeah, our team never says you're not doing well here, and not. It's instead always, here's something that you could do a little bit better to earn a little bit more money, and you'll see great results, right? And that's a different framing of the same point, but it makes a huge difference.
Absolutely. Now, Michael, we are learners on this podcast, and we like to ask our guests what books either they're currently reading or have inspired them, and what might be on their podcast playlist. Would you care to share?
Sure. I just finished No Rules Rules, which is the Netflix book with Reed Hastings and Aaron Meyer. Really enjoyed that. It's about releasing controls and having super high talent density. A players want to play with A players, right? That's very much out there. And then from a podcast, my two favorite lately has been the All In podcast, which is good, just national rhetoric around different topics. And then that's with Jason Calacanis and a bunch of his friends. They're pretty well known out in Silicon Valley landscape, and got to that originally because he does a This Week in Startups podcast that I find pretty interesting as well.
Great. That's very, very helpful. Well, Michael, thank you so much for being a guest on the show and sharing what it is that Stellar Health is really doing to help providers and ultimately help patients and health plans by providing that process to really make it easier for providers to be able to close those gaps in care. It's been very, very informative.
Thank you, Beth. Really appreciate you having me.
All right. And with that, for our listeners, that's a wrap for another week of Be Time, and we will see you in a week. Thank you.